So now we're going to talk about remote care. The extraordinary thing about COVID has been that things that we would have thought would have taken 3 or 5 years even have happened in 3 weeks. And nowhere has that been more obvious than in remote care. And it's not just about remote consultation, although that was the most obvious form of remoteness, but many other aspects too. And it calls for robust evaluation, but how can you research these rapid changes in remote care at speed? And to help us answer some of these questions, can I welcome the members of our next panel, Christi Deaton, Tara Donnelly, John Hurst, and James Piercy. So can I ask you to each introduce yourselves? So Christi, let's start with you.
Good afternoon, everyone. I'm Professor of Nursing at the University of Cambridge, and my interest is in people who have heart failure. And we've been working with this institute to ask people to do some research around their perspectives of how remote care has worked, both providers and patients, and then to do some consensus building around what should we keep and what hasn't worked as well and what do we need to do differently.
Tara, welcome and hello.
Hello, good to see you again. I'm Tara Donnelly and I'm the Chief Digital Officer at NHSX, which is the agency that's been set up to accelerate the digitisation of health and care to benefit citizens and staff. My background, though, is in operational management in the NHS, so I am really interested in what actually works and makes a difference on the front line. At NHSX, our mission is to digitise, connect and transform. And I lead a small team that's leading on scaling the most evidence digital solutions. And our current focus is remote monitoring. We're working in partnership with the 7 English regions to scale remote monitoring solutions in long-term condition management, also in care homes and for the acute COVID response. And I'd be very happy to say more about that in the discussion.
John.
Hello, everyone. I'm John Hurst. I'm a doctor by training and a researcher based in London. And it's been my pleasure to work with this institute on a project looking at the possibilities of remote care for people with chronic lung disease, both from the perspectives of patients and clinicians.
Fantastic. James, hello.
Hi, everybody. I'm James Piercy. Excuse me. I'm a member of this institute's Engagement and Involvement Advisory Board. And I guess my history of engagement with the health service is a traumatic brain injury that I suffered some years ago. But I'm very actively involved as a patient, helping on research groups and trying to keep the patient voice at the heart of everything that we do.
Fantastic. So I want to start by trying to anchor ourselves in what was going on before, PC, pre-COVID era. What was the evidence for remote consultation before lockdown, and what stopped us embracing it in a wholesale way? Christi, let's ask you first.
Well, there's certainly in cardiology, there's been a long history of telemonitoring, which we were using and the studies, though, were fairly inconsistent about how well that worked. So a number of different systems where patients answered questions about their symptoms. They maybe put their weight in, maybe transmitted even an ECG or something like that. So very inconsistent results as to whether or not this worked. It also requires people then to be able to look at those data and make some decisions based on that. But then the other, if you look at more widely around remote consultation, I think we've just been in we're used to working face-to-face, and that's the way it's been done. A lot of the primary care practices that we talked to most recently had already been moving toward more telephone, text, and even some video consultation. But again, we just didn't have a huge evidence base or a great deal of experience, I think, in primary care as to how remote worked.
And so what was the great reluctance in stopping it, moving it forward? Was it simply the lack of evidence, or was it, and I'm looking at Tara here, more about the tech side? And I have to come clean to you all and say that as a reporter on Tomorrow's World, I've been reporting on remote care for 30 years, and it's taken until now for it really to take off. So Tara, what was holding us back?
So I think it was a mindset thing. I think, as Christi has said, people have been used to face-to-face being the gold standard. And in fact, surveys of patients would typically say, and clinicians, that face-to-face would be preferred. People have been extraordinarily accommodating, citizens and clinicians alike, at what has basically been technology thrown at them. And we're hearing the most extraordinary stories. I was hearing one recently from the Breastfeeding Advisor. Now, I'm quite a fan of digital, but I did hesitate to think, well, there are some things where, having somebody in person is helpful. This midwife was reflecting that perhaps in the past she's been a bit hands-on, and actually talking the mum through that experience to do it herself was found to be very satisfying and an incredibly positive experience. We've heard about children having speech therapy at school even, which has been incredibly helpful. So some terrific examples of things that I think in the past, patients not having to wait in the hospital, that kind of hard evidence of people from their experience to see that this actually works has been extraordinary. But I would say most of it has been replacing one type of transaction with another. We're only just beginning to really transform pathways in a completely different way. That's the work that I think John and Christi are very much engaged in, where we fundamentally look at a pathway and we empower citizens to hold that information and lead their care. We're at the foothills of that. That's the really exciting bit. But certainly, I suspect that custom and practice held us there. The technology's been there for a while, and I hope a good proportion of it will stay.
John, I wanted to ask you. I mean, you work in COPD, I think, and chronic respiratory disease, and actually the idea of hoiking somebody out of their home, making them come in on several buses into hospital, sitting next to other people with respiratory infections, that seems to me to be a very good thing to have left in the past. But has indeed remote made a difference in your section or sector of the work?
What an interesting discussion, Vivian. And I think the thing that's come out for me so far is that there's two different things that we're talking about when we say remote monitoring. And one is replacing what we normally do face-to-face with something that uses nothing more high-tech than a telephone necessarily. And the other is high-tech solutions to patient monitoring. And those are very different. And I think we need to be careful what we're talking about in different contexts. So I would agree with you that patients with chronic lung disease, the sorts of people that I look after, are susceptible to acquiring infections from other people. And actually, we can see that because the incidence of those infections has gone down through the lockdown period. So that's a real effect. So if I can deliver my care remotely, then that has to be a good thing. But I can't, and that's the point. There are things that I can do in a clinic with a person in front of me that, at least at the moment, it's not possible to do remotely, or at least it's very difficult to do remotely in the absence of extra kit. And really, that's what our project was about, because we were asking clinicians, what do you think you can do? And we're asking patients, what do you think your clinicians can do? And we didn't very often agree with each other.
James, I wonder if a lot of this resistance to remote care, now I'm talking about remote care, for instance, remote monitoring of vital signs, is actually there's a suspicion of clinicians of patients. Somehow, patients aren't to be trusted, and certainly aren't to be trusted in collecting their own data. How much of that do you think is going on?
I'm not sure that there's a lot of that. I think that there's a lot of resistance at first because this is necessarily the alternative. It's what we have to do because of the pandemic, and therefore it can't possibly be as good. And I'd agree with what the others have said, that we haven't done it sooner because it's just, we do what we do, don't we? That's a very human instinct, isn't it? To carry on doing things the way they've always been done. Why on earth would you change things around? I think in terms of patients monitoring themselves, there's some evidence starting to come through, certainly in brain injury that I know more about, that people can do that and they are quite good at it. It's interesting to take a slight aside, the work that this institute are doing through the Discovery service is showing that lay people are just as good at analysing scientific data as professionals. They can do these sort of systematic reviews just as well as anybody else can.
Hooray! Thank you, James, for saying that.
It can work, and it does work. I think, though, patients lie. I'm sorry, but the classic story, isn't there, of somebody going in to see their GP. What's the matter with you then? Oh, not much. And then the last 30 seconds of the appointment, well, I've got this lump. And I wonder whether there's a risk that some of that gets lost in this move to remote, which always feels a bit more urgent. It feels a bit more pressing, and you've just got to do things that, well, maybe I won't bother to mention that thing then.
That's something I hold that thought, James, because it's something I want to come on to. But I want to ask you all first, what have we learned about remote care since March? What have been our big learnings? Can I ask that question of both Christi and John? John first.
That we can do it, that we should do it. If there's one thing that I want to come out of this as positive, it's keeping the bits of the NHS that have changed going as we return eventually to something that looks more like normal times. So there's no doubt that for some patients, some of the time, a remote consultation where it's possible, for example, to have more than one practitioner on the call at the same time, so we work in multi-professional teams, that's a good thing. Saves travel time, it's more convenient, people are more comfortable at home. So I think that's a positive thing. I think it would be good at some point to have a conversation about whether this might exaggerate disparities. Perhaps that's something we might come on to. So I'm worried that some people may benefit from this, and perhaps in some ways the people who need it most may not. So I'm in two minds about that.
Okay, Christi, what have we learned?
I would agree with what John said. And I think the challenge of an older and multi-morbid group who have a number of problems that can be exacerbated. But I would agree that we've learned that we can substitute much of our face-to-face care with remote measures. Some practitioners are less confident about that. One of the heart failure specialist nurses said heart failure is such a visual thing. When a patient walks in, you can say, so much about their breathlessness, how they're moving, so much more that you can tell, which is maybe more difficult to elicit over the telephone. And oftentimes, worsening of symptoms happens slowly and incrementally, so patients are not so aware of it as would be a practitioner who saw them, say, 3 weeks ago and now sees them now. And that the change is more evident than it was in kind of a day-to-day change. So I think I agree with John, it's keeping that. Many of our patients really liked it because it was efficient. They also thought the providers were actually focused and had read their records before they called them versus sitting in a consulting room with the practitioner focused on the computer rather than the patient because they're trying to read their record or trying to write something. So I think we've learned that's positive, but it also is time consuming. It's not something that necessarily saves time for the provider.
I want to come back to James on that question that you were beginning to raise there. Are some groups marginalised by remote care, and are there disadvantages that we perhaps hadn't really expected about remote care, either remote monitoring or remote consultation?
Yeah, I think there are. It's easy to grab the easy thing and say, well, some people haven't got a smartphone. Actually, we know that that's probably not true. There's not much difference. Most people now have some way of connecting. But there are other things about remote consultations that can be difficult. What if you live in a house of multiple occupation? There are 16 other people in the house and you have paper thin walls. Is that going to work? Probably not. I was speaking to a friend of mine. She has long-term mental health issues and would regularly go and see somebody, a therapist or a social care worker, a health consultant. And I'm going to swear now, but she said it's really important to have a place that you can go and leave your shit there. Mm. So actually being out of your own environment is really important for some people. To go and have those conversations in a different place is really quite important. And also the other thing she mentioned is that when you're sitting in front of a camera, look, I've got lovely, look, it's all books and I'm clever and intelligent, you can't see the rest of the house, which is a complete tip. And actually, for some people, that's quite important. You know, when somebody goes in on a home visit, what they're doing is checking out what's it like. Okay, are you keeping on top of things? Are you coping? And that could be any kind of physical condition as well as a mental condition, I guess. You know, is the person capable of looking after themselves? Can I tell that by looking at them over a camera? Maybe not. So I think there's a whole bunch of issues that it's worth bearing in mind.
And Tara, the thing about digital exclusion is something that I know that will be of concern to you. But digital exclusion, it isn't just about people not being able to work devices. It's also about what your data plan is, because it costs people to be online. And the other thing, of course, is that I'm sure all of us have experienced this who live in places of multiple, occupation, like blocks of flats. When the kids come home from school, that's it. Your bandwidth disappears as they all go and play Fortnite. So, digital exclusion is a major problem, isn't it, here?
It's definitely something that to give great thought to. We were delighted, for example, that all the telcos have zero rated the NHS.UK website for the period of the pandemic. And we're getting 60 million hits a month on that site, which is incredibly important around the misinformation piece. And it's a conversation we're having with our charity stakeholders, because you're absolutely right. A year ago, if you were diagnosed with a long-term condition, thinking about your data plan or the type of device you had at home would be very far down the list. Whereas now it makes an enormous difference, particularly to people who are having very regular transactions. The telecom companies have done a number of important steps, particularly helping vulnerable customers. In many cases, giving them unlimited data, which is really important to make sure people aren't missing out on things like video consultations, particularly if they only have a smartphone and at home they don't have other devices. So it's a very relevant point, and the charities, we think, are quite well placed to be starting to have that conversation with the public about how things are quite different. I did want to pick up, if I might, on your point about learning since March, because one of the things for us has been about how technology can help in acute COVID care, whereas a lot of the evidence that we have, and the evidence is strengthening each year about digital tools, particularly across areas like hypertension, diabetes, COPD, heart failure. There are others where there's less evidence, but we now have quite a treasure trove of evidence in those areas. But NHSX was approached in March by a clinician who was running quite a big virtual ward for COVID, asking was there any technology that could help with that. And we partnered with a kind pro bono offer from a tech company, and essentially offered patients at that hospital the opportunity to go home much sooner as they recovered from COVID. But the deal was entering data regularly with a pulse oximeter. And we found patients of all ages were really up for this arrangement and were amazingly good at tracking their symptoms daily. They also loved the fact that you got a kind of WhatsApp double tick when a clinician had seen your results. They felt very reassured. And on the clinical side, it saved a lot of time, because instead of phone calls slightly in the dark, they were able to really focus on people whose results were worsening rather than those who were recovering brilliantly. So often I think the remote monitoring thing can sound a bit scary to clinicians. So much data, what do I do? Actually, it can help stratify and mean that the face-to-face time is dedicated to those who most need it, as we were hearing from James. Of course, nobody's saying this is for everything, but to give people options would be really super helpful, I think.
So we've got lots of questions coming in. Here's one from Francesca Deaton. In the speaker's experiences, what are the enduring challenges to scaling up or continuing to use remote care? If you'd like to take that, John.
Yeah, and it actually comes back to something that Tara was just saying as well. So the innovation around COVID has been tremendous, but that's actually forced us to think about how we work across traditional provider and organizational boundaries. So whose responsibility is it to be caring for someone who's in a virtual hospital in the community? And if that's a hospital team, it's not that the hospital team have discharged someone and suddenly have all the time and all the energy to be able to devote to that, they've discharged someone onto a virtual hospital because the hospital is full with other people. And so the tech is only part of the solution. There's also a big thing about staff here. And I think that's the other thing that we've not talked about, is the adequate resource to be able to use these new ways of delivering care.
And I wondered what kind of research evaluation you all felt was necessary, and whether actually the horse is already bolted and is way out the stable door. You know, can we evaluate properly something that some patients now have got used to and want, which actually might sometimes not be in their best interests? Christi.
I think it is important that we do this research. And what I was going to say around pick up what John was just saying, is that I think it's important that we look at how this works within an integrated system of care. And that's one of the things that we can research. Just because we've got this potential to link people that are in disparate places in very efficient ways to provide a consultation that includes different specialists and the patient. But if we're not using that in an integrated and systematic way, and it's not part of a program of care, and I think that's a big part of the research. When do you do something for whom? And then understanding why it works in certain circumstances and for which patients. So I think there's a tremendous amount of research that needs to be done. And I think the fact that we're starting to use it doesn't mean that we can't look at different ways of doing it and research that.
A couple of comments here from Andrew Valenzo. Hello, Andrew. Might the old but important arts of medicine, time, listening, touch, empathy, compassion, building trust, be diluted on that line? Does that matter, James?
Yeah, I think it really, really does matter. We're all doing this at work, aren't we? And having these meetings and talking together. What I've found is that it's really knackering. But more importantly, you can't build a relationship in the same way with a bunch of people virtually as you can in a face-to-face room. You know, when I go off and grab a coffee in the break, that's when you get to know people, and that's when you build up that trusting relationship. And I'm sure the same is true in consultations. So actually to meet that person face-to-face, to build up that level of trust, maybe you can switch remotely further on down the line. But yeah, I'd be concerned that we'd lose something if we kind of abandon this trust building exercise early on.
Hands up, you who is missing face-to-face contact?
And Vivi, just to bring us back to John's important division, though, that's about consultations done like this. I think when remote care is done well, patients feel more cared for rather than less cared for, because it's on an ongoing basis. They are in charge, often, not often. There are some great examples like home warfarin management, where people stay in the therapeutic range for longer than if they were trudging up to a hospital every few weeks. So you could, the cartoon version of that is stay away from doctors, nurses, and your health is better. But what we know is that if you trust patients and you give them the right support, they will keep themselves well much more of the time. And of course, long-term condition management is 70% of what we do across the NHS, put a lot of time and energy into that. A lot of that happens in primary care, but too much probably happens in the complications of disease that some of these digital tools could put right. So we have some great examples where the patients involved say they would never like to go back to the old system. They much prefer the new, but that's because they are feeling more cared for. It's not an at a distance thing.
There's an interesting question here from Marie Cooper. Is there work happening to examine the transferability of clinical and other skills from face-to-face to a remote transactional model? Do you think new skills are needed? And how do we investigate and respond to such a need? Very interesting question, Marie. John.
Yeah, there's lots to unpack in there, isn't there? And I think actually we may be able to learn from models that started because of the necessity of doing remote care. So I'm thinking about rural medicine. I'm thinking about remote support for low middle income countries where a specialist is sitting many, many miles away. So there is a lot of examples that we can learn from. I think it's just been new for us in many ways. I certainly think there's training need. I think that the skills necessary to deliver an effective consultation virtually are not the same necessarily, although they overlap with the ones that you would be doing in person. I'm not aware of any training around that at the moment. That's a really interesting question, and I hope someone on the call and in the audience is writing that down and going to pick that up, because it sounds important. And that reminds me to mention medical students and training for healthcare professionals, because their training has been impacted by remote care delivery as well. And not just the way in which they're being trained, but the absence of training for what they're almost certainly going to need to do. It's a great question.
A very good question. And just a plea from Patrick Birch here, lots of other people are agreeing with him. As a GP, I can tell you that lots of ill elderly patients don't have access to a smartphone. Increasing remote care can disadvantage many of the most vulnerable and needy, and ignores many of the benefits of face-to-face contact that can be hard to quantify. There is an opportunity cost to it, which leads me on to another question, which is who should decide? Is it the patient or the clinician about whether a service can be delivered remotely?
I'll have a stab at that one. I think actually they need to decide it together. I mean, the first reaction is that the patient ought to choose, but actually patients don't necessarily always know what is the best thing for them. I'm prepared to admit that. And I think there needs to be some discussion. And coming back to your previous point about kind of research, there's a risk, isn't there, that we conduct some research that shows that for 90% of patients it's fantastic and it's brilliant. It's then very easy to forget about the 10% who are worse off. So I'd much rather see this defined by individual patient preference and the best and kind of engagement and intervention for that individual, rather than by condition or by some mass survey.
This is your point about fibbing. Any evidence on reliability of self-reports on weight to calculate BMI? In my experience, people always make themselves taller than they are. And is there's an additional question there about the research behind why would they feel the need to misreport? I suspect a lot of people are misreporting their weight, not just to doctors, but probably to their partners and other people as well. I mean,
the evidence on hypertension is it's more accurate than rocking up in the risks of white coat syndrome and so on. So I am sure that people are human and don't always tell the truth, but it would depend whether that was the most important signifier. I mean, you would hope as we get connected devices, actually in the future, it would be really easy to track somebody who might have been very depressed, never leaving the house. Wouldn't it be wonderful if their practice nurse sent them a text going, "You've been so active this week, this is terrific," and start having care in a bit of a different way. Just in terms of advice for clinicians on conducting virtual consults, there's a really good publication called The Doctor Will Zoom You Now, by Healthwatch and National Voices, which includes advice to patients on making the most of a consultation and some great insights as well for clinicians on conducting it. And I'd just recommend that to people.
So we've run out of time. It's very sad because I could talk to you for much, much longer, and we've got masses of questions still. So I hope the conversation continues on the forum. But I just want to ask you a yes or no from all of you. Is remote consultation here to stay now? Is it firmly embedded? Christi?
I would say yes, but it needs to be put into that integrated system of care.
Tara?
Yep, I agree, but foothills, we've got the most interesting bit ahead of us, I think.
John?
Totally.
James?
Yes, but not just as a replacement for face-to-face, a new thing.
A new thing. There you are. Well, there's a huge research agenda there. It's been a really interesting conversation. Thank you so much for all of you.